Good morning. Uh, well, we are almost ending MSK. As I talk about, last lecture was the official last topic of my MSK. And today I'll be going over the clinical anatomy part. Trust me, it was really challenging for me what to take and what to reject. There was a lot, but I have to respect the timeline. I have to respect the other factor. I should not increase your cognitive load. And I hope by now you have been through the process. You know what to do and what not to do. I am working on some of asynchronous lectures, and shortly they will be visible to you. In pertinent, I'll be taking a comprehensive section. There I'll be taking each important nerve, where it begins, what it supplies, and if this damage, what are the possibilities. So this will be a comprehensive. May I split in two, or may I'll keep it as one. I'll see how big is the document. Second, vessels, I'll take over. Third, I'm in a process of filming real cadaveric videos, and I'll be focusing and highlighting the main major structures. And I'm working on that, and I'm sure it will be available to you shortly. And I wish it should be available to you ahead of time, so you'll have enough time to go over, look into the material. I'm sure you have completed your last lab session. Now the coming week you'll have a review session. That's only 1 hour. The request to you all, maintain, if your room, if number of student exceeds more than 10, please report. Report doesn't mean write an email. Just immediately in your room there are phones. Press a button which has an arrow. Press it and call Muhammad. Muhammad, we can see there are more people. Because some people will try to enter in others groups to finish their job and go early or this and that, but that's we don't allow. Increasing the numbers and all that, we all have to protect ourselves and we have to protect others. So this should be your job, your duty. Save yourself first and save others. Okay, so look in that, and if there is something happening, please, you are expected to report. And if somebody don't listen to you, we will see what is that. Now, then a very commonly asked question, what will be happening with our OSPE? Is it a face-to-face OSPE or is it a online OSPE? And I kept on answering that no matter it's a face-to-face OSPE or it's online OSPE, the questions are the same. We know how to transform these questions no matter which modality of assessment we're going to use. So we had long discussions and so many factors, so many consideration, and I'll be writing an official email to you all today, I presume today evening, but I'm telling you ahead of time, we have reached to the consensus so far that we will conduct it online. It will be on ExamSoft. It will not be on face-to-face basis because there are risks and chances, and we don't want to expose people in unnecessary into the things. But questions are the same. Questions are already done, and we were prepared. Like, is it being online or is it being face-to-face? So they will remain what they are. There will be no change. There will be significant amount of gross questions, both upper limb, lower limb, and histology. So you are expected to be good. So many of you are asking mock. All what you are doing during lab sessions, you are given tasks. These tasks were having too much answers to be given, but your OSPE will be not that many questions to be answered. But this was a real mock which you have done over these 6 weeks period. And the answers you have seen, you have written down. We were looking into all the answers. We'll give you feedback. Don't worry for that. We were busy a lot in the execution of the blog, so unable to provide you feedback during the phase of learning. But every activity was watched, observed. We were watching at how you're performing in your different discussion thing, who's participating, who's not participating. All that was under consideration. People were observed during their labs. Peer tutors were observed. Well, peer tutors were just beginners, so I can say on their behalf they did a good job, but they need to be given a space because it was their first experience and their learning. And the question which was asked in the beginning of this MSK block, that how you can be a peer tutor. If I wish to be a peer tutor, how I can be a peer tutor? My answer is show your muscles. How you'll show your muscles? Your MSK is due. Score good, be my guest. Simple, period. Score good, you're welcome. No one is staying at a permanent position, people will be changed. So if you have evidence of good score, you're welcome. But I have to take a limited number of people. Their score matters, performance of your foundation matters, performance of your MSK matters, and overall your behavior and performance and all those things. Your collegiality matters. Shortly, we'll be throwing you a survey. You'll be asked about how was your experience with your peer tutors, and that will be helping us to understand more even. I was receiving direct calls, I was receiving direct emails of some incidences, but they were not worth big to be mentioned. They were very few, very short, very little. So anyway, this was about what we did and what we're gonna do. This evening lab will be continued till year one completes. After year one, you will not find any evening lab. And this lab is designed for your learning. It's a voluntary activity, and people were exposed. Unfortunately, this year COVID was the worst thing which affected us badly. We love to. I know there's no tool available yet in this world which replaces face to face. Face to face is the best, but under given circumstances, we have to follow things. Anyway, we are learning, and now without any further delay, I like to start the ball rolling. And as usual, where are you, my dear? Yes. So today I have just touched upon very basic things. So many of them we have talked about, and so many of them we are learning. So I'm going over. Guys, stay connected with that concept of your. I'm waiting for, I think your BLCs has circulated a document with you, and you will be asked to put your questions. Guys, don't get into unnecessary details. Don't get lost into this now, why this and why that. Trust me, we have time. For me, I have time to explain it, but not at the cost of the whole class. So many things. If you need really to understand and you are struggling, you want to do a PhD in that now, you're welcome. Come to me, fix a time, I will explain to you. But what is needed, what is necessary, focus in that. There is a lot to do. We are not expecting you should be writing essays. We'll be looking for keywords. So stay connected to keywords. If you put the right keywords which matches to our key, you are getting full marks. And we don't have a policy to fail people. Our policy is to help people so they can become good doctors. Right? So that's our intention. So to begin with, there I'm showing you a concept which we talked about, and this is pull out elbow. You can see in this image a child, parents love him, it happens. And he has been pulled up, and resultant things have been shown and discussed and explained. What can happen? Why this is happening? I put this question on the discussion forum, and you were asked to explain. People tried. More than 60% answers were right, but they were a little bit glitch in the answer. Primarily, it's the annular ligament which has not developed at this time from age 1 to age 3. Once it's done, it reaches to its normal size and function and how it should be. then this is not the case. But in a preschool and preferably age 1 to 3, that has been quoted in literature. So that says at that time, people wrote the head of the radius is not developed, but what literature says, the annular ligament has something more to be stronger, more to be developed. And that result, so we can avoid this. We love our kids, but that's not the way of loving your kid. This is one. Second, you must have seen people throwing their kids in air, and then kid is coming back and they are catching. Parents are happy and kid is happy. Oh, what a jubilation is going on. I have seen people after this, either the parent is unable to catch the baby, so landing on the floor and having some fractures across the pelvis and other parts where he land up. And worse, even then, when you are having the concept of, if you go back, the concept of physics, acceleration and deceleration, there are some counter coup type of injuries which may occur to a human brain. Be very careful. We have so many things which are connected, but you will be learning over a period of time. But one has to be careful, and one can say if somebody is showing that type of love, gentleman or lady, we can say you are so much, but please be careful. Now, what is this? Bursitis. How you can see someone and you say straightforward bursitis? Or maybe it's a lump. There are so many people, they have a lump, and there is, bursitis word will come when this person has some itis. What is itis? Inflammation. Even without his speaking, I can see to it. I can see to it. Is it red? Look at it. Is it red? Little bit, but not to a. So it could be, it could not be. I will ask the patient. When you move your hand, does it hurt? For how long it's there? If it's just a short story, then we are thinking more of inflammatory changes. But if it's there for longer period, then we are thinking, oh, it could be anything. From a lipoma to whatnot. But that's a site for a very specific thing, and that is related to those who spend good time in their studies. This is also called as student's bursa. So look at it, this is how it is, and this is its treatment. People aspirate it out, and it's been consumed. There's a big description is being given about that. Bursitis of the elbow is exposed to injury during fall. It can happen. So those who are having prolonged hours of sitting, they may develop, but not to this extent. This was being extreme. So this has been mentioned by different names in literature. That what are these different conditions which are associated with that. And if I'm not wrong, when I was talking about arm and elbow lecture, this picture was shown to you at that time. But I didn't find time to talk about it. I just passed by. Okay, ischial bursitis. Another very important condition. I cannot bring any image. We all know when we sit on ischium. Now, if we are sitting on for prolonged period on hard surfaces, and then we are doing some more traumatic situations. So as a result of that, the ischial tuberosity, we have so many important muscles are connected there. Can you name those muscles who are attached to your ischial tuberosity? Guys, if we ask about origin insertion, this type of question will be put in. So you should know what are the structures which are attached there. That's it. I remember some time past, we asked about this muscle is attached, some part of the bone is being fractured, and person is unable to perform this action. So which was the option of the muscles? Yesterday somebody stopped me and start inquiring me that we heard seniors were saying you people ask origin insertions. Luckily, I found two other people, they were just passing by, and those who have seen our exam, I asked them, please stay beside and tell them Did you find any question last year in MSK exam? And the answer was obvious, it was no. So if we ask, if you think this is origin insertion, this is not origin insertion. But you are exposed, you are expected to be good at it. What are the muscles who are connected to my greater tubercle, lesser tubercle of humerus, to the greater trochanter, lesser trochanter of the femur? So this type of info is needed. At least you should know what group of muscles are there. So this is what is being expected, and we should be good with these things.
And the tiny detailed muscle,
No way. If you have time, enjoy.
only the major muscles.
Major muscles in more, if you open up those charts where it's written exactly like that, name of the muscle. First on top, group of the muscle, name of the muscle, proximal attachment, distal attachment, action or function, and nerve supply. If you are good with those tables, you are fine. Even that table has more. When you go to the nerves, you'll find name of the nerve, then source, then course. Course, if you think you have enough time, read it. If you don't read it, you will survive. But if it damages, what will be lost, and any associated clinical condition, that should be known. So that we will be inquiring about. For arteries, from where it's coming, where it's ending by means where it's changing its name, and what are the major branches given on its way. And if these branches are taking part in making any type of anastomosis, that you should know.
So is that a safe bet to basically?
Can you move it down because
So is it a safe bet to basically just understand, like, for example, the medial epicondyle, which is the golfer's elbow, and the lateral epicondyle, which is the tennis elbow.
Mhm.
So because since it's flexion, so you do know what the flexor muscle attaches to that epicondyle. Are the questions more directed towards those clinical?
No. Thank you. You asked me this question. His question was, I know you don't understand what he was talking, but let me try to sum up for on his behalf. He was asking how these clinical questions are written, what pattern is being offered. Guys, when we write these questions are written, age has something to do with that. Youngsters have different problems, middle age has different problems, childhood has different problems. And then they are targeting about an event. Time duration is given. Time duration says it's a short period thing or it's a long thing. It's an acute thing or a chronic thing. Third thing, we always give loss of something, loss of some functionality or loss of some pulse. Let me give an MSK example. Loss of some action of a muscle, loss of some cutaneous nerve supply, loss of some part like pulses are not there. So these type of clues has been embedded in that. And then even if you don't see the choices, you know what we are asking. When we develop our question, we develop with this philosophy that if we cover the choices, if we cover the option, by reading this vignette, student can reach to. This is the beauty of single best answers. True false, yes, every statement is detached and we are not using true false. EMQs, we are not using those. We are using SBAs, single best answers, and we are following NBMA. So our questions, vignettes are written in such a way. Either, and usually our question ends with which one of the following. That will be the last thing. So spend time in reading, break up in your mind and see what has been targeted. If X-ray has been provided, it's not been provided for a fancy show. It leads you to a clue. Let's say if somebody falls on an outstretched hand, oh, start thinking. How old is the person? Adult. Oh, scaphoid. First thing first, scaphoid, colis, distal radius. Then, if it's a child, I will be thinking more of supracondyle. May fall on an elbow, may fall on an outstretched hand. Supracondyle. Then clavicle. Right? Some old lady, especially lady, slipping in a toilet. I'm targeting femur neck, intracapsular. A youngster after a bike riding thing, intertrochanter fracture. Make sense? So this is how the things are connected, and these are keywords. So you should be able to catch. You'll open some resource books. They have so many complex type of MCQs. No, that's not needed. Do according to your level. When you are getting in practice, let's say you are using a book a lot, BRS. If you look at the question of BRS, some one of them are super easy and some one of them are very difficult. If you go to the online resources, you'll find there are questions which are super easy. You're doing it, you're doing 100%. But reality question, because we are not using, maybe if we use some of these resources which are available to you, we may use a picture from there. We may use some vignette from there, and then we can, we know how to play with the things, and we try to bring things in reality, in connectivity, and don't forget the cutaneous nerves, how and where they supply. I remember last MSK exam, there were so many questions on sensory supplies, and people were lost with that. So please put something in your mind, and then what are they and what is happening. Anyway, so this is how we really see. I don't believe in keeping secrets. I believe in people should know. And if somebody is good with that, yes, come join the club. Pass the exam, proceed. We are not penalizing you. We are helping you. But you should be taking step forward. If somebody has not bothered to open the presentation till today, what should you do for him? If someone asks you how to do this and that, excuse me, this is not the time to open a new book. Somebody was asking me about a book for some other subject. I know a book, but I was thinking I didn't answer that person because it's so little time left, 1 week. How that person will be able to cover that book? So, whatsoever you have done, stick to that. Anyway, we'll talk about it. So this is another thing, hamstring injuries, they are associated with sports related activities. So you should be good. Guys, these things I have taken from the blue boxes of Moore. So don't get stressed, don't write it if you open your Moore, the blue boxes. I just taken these two, this slide is copy pasted from there. So I'm not keeping any secrets. No, this is a conceptual thing where you need to understand. And I'm sure you have some concept. Look at it, my femoral triangle. We all know its boundaries, we all know about this. And look at it. This femoral triangle, it becomes like a tunnel. And when it becomes a tunnel, this tunnel is called adductor canal. And the lower end of this tunnel is adductor hiatus. So the structures who enter from the pelvic cavity into my lower limb, they pass through this funnel. They do what they're supposed to do, then they narrow down. They run in a tunnel. Who are running? Primarily those who have a long way to go. And then they exit out through this adductor hiatus. This is a very nice picture. I think Gray have this, most likely. So, but this gives you a connectivity, how your femoral triangle is connected with adductor hiatus through adductor canal. Now, this is another area where you need to look at it very carefully. The acetabular foramina, and then the transverse acetabular ligament, and there's a gap. And that arrow, little blue arrow, which is pointing upwards, that's the place from where the obturator artery is entering into the cavity of the hip joint. And this artery is very good, functional in early days of our life. Right? So it is saving even if the medial, we talk about the medial circumflex femoral artery is the key artery for femoral neck and femoral head. Guys, I saw some of the emails. Some of you are still confused with the, these branches. Please remember, the head of the femur has supplies from so many resources. But if you find this question in your finals and you are given choices, the one best which fits with that is medial circumflex femoral artery. If you have to choose between lateral and medial and blah 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 blah, you should be clicking medial circumflex because that's the main source for supplying to the head of the femur. When you're writing your exam, your info should be at pinpoint. If you are right on dot, I don't see any reason that you're going to lose something. You are under stress, you are in a hurry, and it results in what? Oh yeah, I know it, and then you are deceived. Please look at it. I always spend time when we review the question that is any question matching with the available resources, then we change it. So be careful. If you find some minute which looks similar, oh yeah, I saw these lines, I saw in that in this and that book, okay, these lines may be matching, but there may be something done with that. So you have to be careful with those things. Otherwise, yeah, I did it right. And once you do it right, no matter the whole class did it right, then you are jumping, oh, I did it wrong, so it should be cancelled. Gentlemen, look at it. More than 300 people did it right. Why we delete it? And there are so many questions you don't know, we delete them. Because we have the item analyses that explain to us that what is happening with this question. Each item, these questions we call them items, each item has its own behavior and that has been shown in a short period of time. So there are a few questions you think they are very easy, but we see that if we see their analysis, that's not that's not showing what people are thinking. Then we do so many things because our ideas are to help people, not to destroy people. But you should be connected with this image that how the obturator artery enters, and this obturator artery is functional in early days of life. Once people reach to the puberty, cross 25, 20, 25, epiphyseal lines and things has been done. So beyond that, even later part of the childhood, this is no more functional. I think if I'm not wrong, after 15, it's of no use. But obviously, if I wanted to ask about obturator artery, I will be giving you an age line of 5 years, 6 years, something. So that means my target is obturator. So you should learn how to connect the dots. Okay, now this is another site. The peripheral pulses. Today I'll be talking in the structure of the week session, guys. Whatsoever is being taught to you during lectures, during labs, during structure of the week, all is even during TBL, all is included as your is all covering according to your objective. So stay connected with each info. All the lectures which are visible on the Moodle, all the links which has been provided. So you should be making a justice and you should be able to be good with that thing. I will be talking on in my review session that how you can score best in your MSK. That remind me at that time. So this image is basically showing you this big blue arrow is primarily showing me that what are the structures which passes through this, and we know that that is my flexor retinaculum. So now I'm using a term here again, tarsal tunnel syndrome. We talk about carpal tunnel syndrome. So that's a tarsal tunnel syndrome. Same type of mechanisms, but the pathophysiological concepts are a little different. It's not related to pregnancy, it is related to more other factors. We don't want you to engage in those, what are those factors, but if things have been trapped, then you can figure it out what could be happening to these structures. So now, if I compare this carpal tunnel with tarsal tunnel, my carpal tunnel was not having any artery going through that, but the tarsal tunnel has an artery also. So we should be thinking for some kind of ischemia, some kind of decrease in the flow of the blood, some kind of discoloration of the digits. So you should be connected to these keywords. That's really, really important. Okay, now Dr. Ayman spent good time on this. He, in the previous, I remember one of the structure of the week session, he brought a case where somebody has broken the neck of the fibula. And there you can see how my common fibular nerve and its branches. Yeah, good, I remember it. Somebody was asking me a question and I thought I should answer for the whole class. So max people can be benefited from this answer. He was what I consider, if I'm not wrong, what he was inquiring me, like if there's an injury, if there's a fracture at this level, what will be lost and how we know. So guys, if my common fibular is lost, both my deep and superficial will be gone. If superficial is gone, so deep will be functioning. If deep will be gone, then superficial will be functioning. And anything before than that will be functioning. Let me give you an example. We talk about fracture mid shaft of the humerus. And there we always talk radial nerve. We talk about profunda brachii, not femoris. Profunda brachii. Now, when you go into the details, the radial nerve, before entering into this spiral groove or the radial groove, it managed to supply part of triceps. So that part of the tricep will still retain its function of extension. But radial nerve is damaged in the radial canal. So the branches given before than that, they will still function. And branches after the trauma, they will be gone. Same with median nerve. If median nerve is damaged at the wrist, so my thenars will be affected because recurrent will be gone. But its innervation in my forearm will be there. Somebody was asking a very interesting question, and I didn't took it. It was suggested question for today's structure of the week topic, and that gentleman was confused with that. He put it musculocutaneous nerve supplies brachioradialis. I was shocked when I read that. Please correct yourself. Musculocutaneous nerve supplies coracobrachialis, biceps brachii, and brachialis, and after that it continues as lateral cutaneous nerve of the forearm. It has to do nothing with any muscular supply. Further, it is available on the lateral supply, cutaneous supply, sensory supply, and my brachioradialis is having a supply from the posterior cord branches. I told you brachioradialis is a very unique type of muscle. It is coming from humerus, living with the extensors of my forearm, eating with the extensors, taking their supply, and functioning when my elbow is in mid prone. At that time, it's giving me flexion. So, if my musculocutaneous is damaged, musculocutaneous I get it from where? From lateral cord. After giving lateral medial pectoral nerve, if a muscular, even I remember I used this question in your TBL. So, if musculocutaneous has been cut, still person can perform flexion at his elbow. The reason is this flexion at the elbow was achieved in mid-prone position. It's not a normal flexion. And please, musculocutaneous nerve never ever supply your brachioradialis. Maybe you got confused with coracobrachialis. So please check your words, what you're asking. And he wanted me to discuss this as a structure of the week. So I said, what the hell is this? Anyways. So I make 2 million mistakes. When I'm talking, maybe I'm talking north and I'm saying south. So these errors are always there. And you are always recommended that you should go and check if you have any conflict arising. Somebody was showing me, this has been mentioned here this way, in the lab material the other way. My answer is infos which has been connected to your book, Moore and Gray's, they are number one. Anything after that. If you have a problem with any of the concept, go back to the book. Check yourself there. I remember when I was talking about the lateral and medial plantar nerves, the divisions, I said there is typo. Lateral is written medial and medial is written lateral. So it happens. Even textbooks have these shortcomings. So many times we identify to the authors and they correct those things. So many, I know there are so many things which has been corrected and I have so many thanks from those authors that, oh yeah, we did it. I know there were some images in the description of the same book. It's written right, but when they came to the image, they made a mistake. It happens. So the best thing is always go refer a standard book. I will not be using, guys, I have seen maybe more than thousands of anatomy titles. And every book is more beautiful. I love every book, but I will not tell you go through every book. Go stay focused with one or two books. And if I read something from 10 books, how many times I can read one time? So my knowledge will be a little shaky. I'll not be really clear about it. But if I learn it from one book 15 times, I'm sure of it, what I'm saying. Anyways, so with this image, what I'm trying to show you here, if you are given a fracture, a clinical scenario, where somebody after an accident has fractured his neck of fibula. Now, and there is some loss of function. Loss of function means some nerve injury. Then you can connect it. If I'm bringing a loss of function from anterior compartment of my leg, I'm targeting deep fibular nerve. If I'm bringing a loss of function from the lateral group of muscles, I'm targeting superficial fibular nerve. So you should be good with these dots. I'm sure you are smart enough, you can handle these. Now, this image it was just a fun thing, nothing specific, just trying to show you a section of my thigh and look at it, how the muscles are surrounding the femur bone. Ayman was talking about linea aspera. This is linea aspera. And look how many muscles are attached there for such a tiny place. But anyway, this is just for to show you how these muscles are whirling around, how they have been surrounded the femur bone, and it gives you more precisely a concept of compartments. You can see very clearly where is the saphenous nerve. We all know what is a saphenous nerve. It's a continuation of femoral nerve, sensory branch. Then you can see a big green thing, that's your sciatic nerve. Are we good? So you should have an orientation. Now, plantar fasciitis, a very common disease, a very common problem, which affects humans a lot. And when I remember when I was talking about foot in my foot lecture, I talk about that. So basically, you can see what is happening, where is happening at this part. At this part. So there are multiple factors, but your standing, walking, driving your car are extremely difficult. You cannot touch the floor. It's so painful. This condition is being labeled as plantar fasciitis. And it affects, I will share with you, no need to write, Khalid. You'll get it. It's not like, even I mentioned the source from where it is, it's from letters.
Is there a common manifestation with Flatfoot people?
Hmm?
Is there a common manifestation with
No. It has to do nothing with flat foot. It is anybody who's normal. Even flat foot is normal, but only his arches are not there. Any person, anyone, you, me, or anybody living in this world may have this problem. Like, tell me, any person living in this universe can say that I can never have a fever because I'm superman. Anybody can have a fever. Same is, this is an inflammation. So anybody can have it. It's not necessary that you may have or you may not have problem with your arches.
I was asking, like, is it more prone to be chronic with Flatfoots?
No, not really. I have seen a lot of diabetics, they have this. But those who are using a lot, those who are using their foot a lot, so they, when they got it, let's say a driver, if he get plantar fasciitis, his job is what? To use the, unless he got a car where, everything is in his hand. If you're using your foot, there are some surgical procedures where surgeon is using his foot a lot. Can you think of a surgeon is during a surgery using his foot a lot? Think of dentist. Yeah, I know. Yes, but not to that extent. I'm saying a lot. All his move is on his foot, and he's doing surgery. Think.
Standing.
Standing?
Yeah, for long hours.
No. That will give him varicose. That will give him hernia. Any idea? A urologist, when he is operating, because all the urology work is endoscopic, 99%. If he is a urologist of today, I'm not talking about urologist of yesterday. His all work is endourology, through scopes, through manazir. Now, he uses his hand for controlling his instrument, and his foot is helping him where I have to burn, where I have to caulk, where I have to burn, where I have to caulk. So he is using, like, when you're driving your car, do you really notice how many times you press the accelerator and how many times your foot is trained? Automatically you are shifting. And if the time where you have to apply a brake, if you have applied the accelerator, then you had it. It happens. So same is when we are operating through endoscopes. Look, we are in the urinary system. An artery is bleeding. So my foot has a control. I press that part so that bleeding artery will be buzzed off. So these type of things are, So these people, example was these people who are using their foot a lot for very wide, like a driver is suffering from fasciitis, plantar fasciitis, and he's driving a car. He has to stop the car, and it's really painful, so he cannot do that. Maybe he can do it once or twice, but definitely you can hear a big bang sound behind you, or something happened. So it affects, and then it has a long cure, but there's a cure. For every problem, there's a cure. You may get it today, you may get it tomorrow. Like COVID, we are learning. Inshallah. With a period of time, the mystery will be solved. But till it's there, we have to cover. Okay, guys, so now septic bursitis and arthritis. Look at this lady. Now that era is gone. Now they become modern. They are standing, they have their cart, they're using brushes and all. But this was seen in recent past. Maybe 40 years back, this was the standard practice. And still, some places you might see those who are cleaning your home and preparing things. So these maids, they are on their knees. And as a result of that, they have chronic irritation of the bursas, which are present in front of their patella. We talk about supra and infra, then we talk about, if you remember, superficial and deep. So they might have a chance. And look at it, her knee. Gentlemen, remember when I was saying to you, you came up with an answer, it is bursitis. So look at bursitis. It's red. So if you have acute, it will be red. If it's a chronic, redness will be gone. Let me give you an example. You have a cut, you have a pimple, that area will become red. You touch it. Pain when you touch it, this is not called pain, it's called tender. Tender. The word tender, you use it, tender chicken, but that's a different story. If you develop a boil on your forehead, on your face, and if somebody touches, you go away because it hurts. This hurting is called tender. I examine a boil on the face of so and so at this location, and it is tender. If somebody writes in his notes, tender means it's painful on touch. That's the word which is directing to that direction. Like say I'm examining an abdomen of someone and I write the abdomen is fine, moving equally with each breath, but it's tender in this region. Oh, there's a click. So there is something inflamed underneath in that quadrant of my abdomen. Upper part, lower part, right part. You'll be like, GI is coming. We'll be talking there. So, are we good? So this is basically, these are the images which were there just to show you. Now, what are you looking at? Foot. Thank you very much. I'm glad people didn't say hand. So it's a foot. Now look in this foot. Is there anything more?
Yeah, the finger. There are 6 fingers
Really?
or 7.
There is a
But before that, can't you see something red? I'm sorry, this picture is very small. At the ankle, can you see it swollen? So, what it is, we need to look into that. Who's this? So I can see something. When I look at the arches in this section, I can see there is some extra whitish gelatinous substance is being shown. That is, I aspirated out. I did an MR. I aspirated out under the guidance. I found it's a pus. Pus? Sadeep. Now, look at his vascular supply. When I was palpating his vessels, I found some decrease in flow. Something is wrong. I look at his foot. Look at his big toe. It's almost bluish to black. We call it gangrene. Who's this person?
Diabetic.
He's a diabetic. For the diabetics, it has been said, take care of your foot as much you're taking care of your face. So for diabetics, I know a lot of people surrounding us are affected by this, and now people don't call it a disease because it's a common thing. A big number of people are affected. So those who are diabetics, they are always advised when they walk, they should not walk barefooted. They should be wearing shoes which will be covering their foot completely. If a small puncture, if a small trauma occurs to their foot, they should be super cautious. Otherwise, they will end up with this, and the answer to that is chop that off. And that chopping off is called amputation. I still not forget early days of my surgical residency. I spent good time amputating digits like that, and it's a big number of them. Every list, there was a series of people waiting. This digit has to be chopped, and trust me, when you cut them, there is no bleeding because one of the pictures showing up here, even the vascular pattern, there are issues with that, vascularity issues also. So that lead to this thing. So I'm not. I know I have opened up a big subject. We are victim of 3 diseases in common. What are those diseases? Cardiovascular diseases. Then we have peripheral diseases and we have cerebral diseases. All of them are associated with vessels. If the arteries of my heart are involved, we have cardiovascular diseases. If we have arteries of the brain are involved, that lead to your stroke and all those things. Those are cerebrovascular disease. So all vessels, and if the extremities, especially the lower limbs, if the vessels are involved, which vessels? Femoral, popliteal, anterior tibial, posterior tibial, dorsalis pedis, all these things. When they are involved, we have issues of vasculitis, and they lead to their own endpoint. Cerebrovascular disease lead to stroke, cardiovascular disease lead to a heart attack, cardiac failure and everything, all connected. And then the peripheral diseases, peripheral vascular diseases, they lead to amputation and everything. And they all are connected. So vessels, vascular system is really important. So today I'll be spending little time during structure of the week session. I was thinking a lot what has to be there. And when I select something, I select on the basis of merit. That what is something where people should be very clear of. So stay connected. I'll be talking about that shortly in the early phase of my today's, because today I'll be like Sadia will be starting, then I'll be taking over. Then Oni and Ayman and Shahid will be talking. I hope you're good with this. Any further issue? Guys, this subject which I'm dealing right now, give me, I'm not saying hours, give me days, months, years. There's never ending stories. And I know it's interesting, but I don't want to involve you in this that much interest at this time. This is not the time. This is the time. Go back, open your books, start doing your practice. This is the time to practice. I'm sure you all have some kind of MCQ pools, other thing. Connect to your resource material and start practicing. And that's how you can survive. And inshallah, I'm sure you are surviving good. You will be surviving good. Uh, we don't believe in surprises, and I hope I will committed to that. I'll stay committed to that. That there should not be any major surprises. But surprises are, there are two type of people who are never worried. Can you tell me who are these two people? Can you say loud? Thank you very much, gentlemen. Those who know everything, they are least bothered. And those who know nothing, they are super least bothered. Because they know they cannot do anything now. Only they can guess with, oh, this option is long, let me take it. This is first option, let me take it. This is last option, let me take it. When we are reviewing your questions, we always look into that. Oh, right answer should not be long. It should not be first. It should not be last. It should not be queued. It should not be starting with the word which I'm asking. It should not starting with K and there is a K down. So, we learn all these things. How and where, because we've been through the same process. Only the difference is I was born early, you have born late. That's the only difference between you and me. Today I'm standing here, tomorrow you'll be here. Inshallah. So guys, I think with this note, I like to stop. There's a lot, sky is the limit, and inshallah, tomorrow is ours. Stay blessed. Thank you very much. You're welcome. 1 minute. Let me finish this game here.